Hi everyone, it's Sarah from Head Office here. Welcome to this webinar. Thank you very much, David, for joining us today. It's been long awaited and a really great topic to be talking about. Bit of housekeeping, everyone. Everyone will be on mute and with their cameras off. Otherwise, obviously, it'll be very chaotic. Comments and questions, please put into the chat box or the Q&A box, either or. I'll be checking both. If you're having technical issues, you can chat to me in the chat as well. It is recorded, so if you need to dip out or anything happens, you will be able to see it in a few weeks when we get it up on the website as well. So I will hand over to David to do an introduction and then to present his slides. Thank you, David.
Thank you, Sarah. Welcome, everyone. Can everyone see that? So my name is David Griffiths, and I'm a gynecologist, and I'm going to be talking today about the menopause, HRT, and EDS. So a bit about me. I qualified in '87, so I'm quite old. I did most of my training around the UK in the Midlands, West and East Midlands. Spent some time in New Zealand. Went to Boston in the States to do a fellowship in urogynecology. Then went to work in Centre for Endometriosis in Atlanta. I've been a consultant in the UK for sort of 24, 25 years. And my main specialities are period and pelvic floor problems, endometriosis. I'm also an accredited British Menopause Society specialist, and I am not an expert, but I have a strong interest in EDS. So my disclosures. So these are the things we're going to talk about this evening. Why is the menopause important? You hear these terms perimenopause and menopause bandied around, and it just gets a bit confusing sometimes. We can talk about how can you tell if you're menopausal, the types of HRT out there, the risks and benefits. Most ladies want to know about testosterone, the misconceptions and myths about HRT, and just because you take HRT, it doesn't always work for you, and we're going to discuss some of the reasons why. Excuse me. So the menopause is basically when the ovaries run out of eggs, and the average age in the UK is about 51. Now, some ladies will go into an early menopause, and that's when the menopause is below 40, where they're below 45. And if they have a premature menopause, they're below 40 years of age. And the word perimenopause, what that means is any time from any first symptom or a blood test which shows deranged levels till 12 months after the last period. And we describe postmenopausal women as 12 months after the last period. And the reason we have to have that as doctors, because we need some cutoff, because some bleeding, most of the bleeding is quite normal, but sometimes the bleeding can be an early indication that the lady's got cancer. So if you had your last period 8 months ago and then you have another period, you have to start the clock all over again. But if your last period was 13 months ago, it's very likely this was just a late period, but it still needs to be reported to your GP. So why is it important? Well, in the 1900s, most people were dead in their early 50s, but with life expectancy increasing until very recently, until COVID, women were living probably about a third to half their life in the menopause. So the causes of menopause, I say, basically, you run out of eggs. In the fetus, there's about 2 million. At birth, it's about 400,000, and through puberty, it's about 500. Now, some people will go through an early menopause because they meet somebody like me, and we do a hysterectomy and take their ovaries out. Some ladies are unlucky enough to have chemotherapy, and that can stop the ovaries working, so they're very sensitive. You might often hear about ladies who've lost a spouse or something tragic's happened in their life, and their periods will just stop for a while. So we talked about premature menopause. So this is below the age of 40. Probably about 1 in 100 ladies have a premature menopause. Below the age of 30, it's 1 in 1,000, and below 20, it's about 1 in 10,000. Most of the time, we don't find a cause for it, but certainly if your mom or your sister had an early menopause, then you're more at risk. Sometimes with autoimmune diseases, this can cause an early menopause. Certain chromosome abnormalities, there's a condition called Turner's syndrome, that can lead to an early menopause. And then there are correctable causes, such as a raised prolactin, thyroid problems, or systemic disease. And the reason premature ovarian failure needs to be picked up is because if you do have an early menopause, unfortunately, you put yourself more at risk of both heart disease and osteoporosis, as well as increasing the risk of dementia and Parkinson's. And the recommendations are, if you're under 40 and you have a premature menopause, then you should have some hormone replacement therapy at least until your early 50s. So this perimenopause, what's that? So I mentioned before, it's the time leading up to the menopause, and this can go on for 7, even 11 years sometimes. Probably about 1 or 8 ladies will have no symptoms at all. The periods will just stop one day. I must stress, these ladies are in the minority. About 1 in 10, 1 in 8 will have quite disabling symptoms with the menopause. And basically that means probably about 9 out of 10 ladies have some symptoms of the menopause. So the menopause means different things to different people. For some, it's a new phase of their life. They may have suffered with heavy, painful periods, discomfort with intercourse. The periods stop and they feel so much better. They're not anemic anymore. They don't have the pain with the periods. And other ladies, it means something else. If they've been wishing to have a baby and they haven't, then the loss of their fertility. Some ladies will find that they think, oh, it's a new phase of my life, which is I'm on the downward track. So it means different things to different people. And I have to stress, it means different things to everyone, and you should not really compare your symptoms with somebody else's, because every woman is really different. So I'm not sure if any of you live around Swindon, but one of the places I work mainly is in Swindon. It's this roundabout called the Magic Roundabout. And there's about 7 roundabouts here, all around a central one. And it causes a lot of confusion, especially to the Americans who visit the city. But for some ladies, this is how it appears when you go into menopause. There's lots of information out there, and there's so many ways to go. You just don't know the way to go. And it can be very confusing. I don't know if any of you have seen this slide before. It's the 7 doors to the menopause. I showed this to my wife and I said, oh, do you recognize any of these symptoms? And she goes, oh, 1 or 2. And I didn't tell her I recognized about 5 or 6. But these are some very common symptoms which ladies will get when you go through the menopause. So what are the symptoms? Well, most ladies do know about the hot flushes and the night sweats. And these can be quite debilitating at times. If you're not sleeping, which is a form of torture, and it can lead to tiredness and irritability. Some ladies get cyclical headaches. I see some patients who've been referred to the cardiologist because they have palpitations. And it's important to stress that some ladies get loads of symptoms. Some people may only get a minor symptom, 1 symptom. So I say every lady is different. So some ladies, all they present with is palpitations. If they've got a family history of heart disease, they're obviously concerned they've got an underlying heart problem. Most of the ladies haven't, because your heart is actually protected until you reach the menopause. So I see lots of ladies who've been to the cardiologist, they've been given a clean bill of health, and all their symptoms are actually due to the perimenopause. A lot of ladies get mood changes. There are changes in the connective tissue, and of course, EDS patients already have problems with their connective tissue. As people without EDS, as we get older, our joints become a bit stiffer. And lots of ladies will complain of joint pain when they reach the menopause. But interestingly, probably about 20% of patients with EDS will actually say that their joint pain actually improves from the menopause because their joints get stiffer. A lot of ladies will complain about cognitive function, And as we get older, we all forget things. We'll go upstairs and can't remember why we went up. And that's normal because our brain gets filled with lots of rubbish and things. But it can be quite acute at the menopause. And a lot of ladies worry that they're developing early dementia, especially if it runs in the family. And a lot of ladies will get something they call it brain fog or word blindness. So they can see an object and they can describe it, but they just can't think of the word. My wife is exactly the same. She said, oh, that thing over there, it boils water. Mom, it's a kettle. And that is very common. Just going back to the vasomotor symptoms, these are the hot flushes or power surges, as some people call them. So these are basically related to the falling levels of estrogen. If you look at ladies who in their 70s and 80s, they don't get hot flushes. They're menopausal, but they don't get hot flushes because their estrogen levels are very low. So these vasomotor symptoms are due your body's response to the falling levels of estrogen. Now, some ladies cope with them quite admirably, but some ladies are again, quite debilitated by them. So a lot of these symptoms cause a lot of stress and anxiety. And as mentioned before, the lack of sleep can cause exhaustion. And you know, it's like when you're tired, every problem becomes a big problem. Whereas if you're firing on all cylinders, you know, a little problem, you just jump over and go on to the next one. People recognize the same signs of aging. They look in the mirror and they see, they may feel 21, but when they look in the mirror, they can see their skin has changed and their hair has changed. And it affects their general health and energy. And a lot of ladies will describe a loss of libido, which is not surprising. For those of you who have children, you'll probably remember in the first few months you chose sleep over sex every time. A lot of ladies, when you get to menopause, will say, well, I just feel dead below the waist. I'd rather have a cup of tea. And these are very common sayings I hear in clinic almost on a daily basis. So all these factors, they do reflect relationships and self-confidence, how you look and how you act at work. Near us, they have the major branch of Nationwide, the head office. And they realized that they were having lots of disciplinary meetings with women of a certain age. It's suddenly clogged on that it was possibly the menopause. So they invited myself and the nurse over to come and give them a talk. And they've now set up like a menopause group for the people at work. And it's beginning to catch on. In the Swindon Local Council have done that now, and Intel, which is close to us. So a lot of these big companies are becoming a lot more proactive for their employees. Unfortunately, the NHS hospitals are a little bit slower, but most of the big businesses are actually very forward thinking on this. So I mentioned about relationships. Men change as well. So you your partner may have looked like this, but invariably probably looks like this now. So we change as well. So that's not to be forgotten. So one of the other common symptoms of menopause, we mentioned about hot flushes and night sweats, is something called atrophic vaginitis or urogenital atrophy. Basically what that means is the vagina's dry. And that can have problems on the bladder, where people describe going to the toilet a lot. They feel like they've got infections all the time. And this is hugely underreported and definitely undertreated. It's very common in the menopause when you've been 5 to 10 years after menopause, but you can still be having periods and you can have these symptoms. And the GPs will think, oh, maybe it's just a urinary tract infection. So when people hear the word cystitis, they automatically think infection. But what cystitis actually means is inflammation of the bladder. So when ladies first start having intercourse, it's very common to get what we call honeymoon cystitis. And that's usually an acute bacterial infection. And it's treated very quickly by antibiotics. But when ladies are in a sort of been in a steady relationship and they start to get cystitis symptoms, there's something else going on. It's very unlikely that it's a bacterial infection unless they're around the time of the menopause. So we often see lots of patients with something called non-bacterial cystitis or interstitial cystitis, which is also seen with patients with endometriosis, which I see quite a lot in patients with EDS as well. So there are all these things to take into account. So we can see on the left-hand side the uterus, and you can see how thick the muscle is and the lining of the womb, but also in the vagina here, that you see all the rugae, which is the peaks and troughs of the vaginal skin. But as the vagina ages, the skin becomes thinner and the tissues become thinner and the cells become thinner, and it becomes dry and thin. What that causes is a lack of lubrication, which can cause discomfort during sex. Some ladies find that it becomes a bit like sandpaper, and of course the partners don't want to hurt them, and the ladies don't want to get hurt, and that can cause a low libido. Some ladies will say they get just an irritation down below. They feel it's painful, they find it difficult to ride a bike. Some ladies can get discharged. In severe cases, you can get bleeding, and they say it can cause relationship difficulties. And when you see a lot of ladies in clinic and you ask them, do you have any vaginal problems, discomfort or dryness? And they go, no. But when you examine them, a lot of these ladies do actually have very dry tissues, and it's because it's insidious and they're just getting used to it and they forget what it's like to be normal. And so you can give them some vaginal topical lesions, but within a couple of weeks they say intercourse is so much more comfortable again, and they feel so much more comfortable in the area. And they can also help with the urine infections as well. So the long-term effects of the menopause is obviously collagen loss. So when ladies hit the menopause, the bones begin to thin, and roughly there's a 1% of bone loss every year. When bone becomes thinner, it becomes something called osteopenia. When it becomes very thin, it becomes osteoporosis. And patients with EDS, this may already be advanced, because as you're aware, a lot of patients with EDS have GI complications, possibly malabsorption problems, and they have a lower bone mineral density than their matched controls. So the people with EDS may be at higher risk of osteoporosis. I'm a great advocate for HRT, and when I see a lady, I have to find a really good excuse not to give her HRT. So I'm a strong advocate for it, and I tell people with EDS to have HRT if they can. Ladies will also get this decline of cognitive function. Ladies now, if you're working, people used to retire at 55, that's gone out the window now. People are working into their 60s and beyond. And I mentioned this before, you lose your cardiac protection. We'll go into that in a bit more detail later on. But ladies are unaware that when you get to the menopause, up to the menopause, you're protected, your heart is protected. But when you get to the menopause, you lose that protection. So this is a really good infographic from the British Menopause Society, and I'll give you the web address at the end. The other web address, if you can see this, is the Women's Health Concern, which is a really good website, very factual. There's a lot of incorrect things on the internet and social media, but this is a really good one. So you can see most ladies with the menopause find what work's a struggle. Social lives take a back seat. I get patients in clinic who have quite high-powered jobs to go through the menopause, and suddenly they have quite crippling anxiety, and they're just worried about driving down the road. We mentioned about intercourse and sex, that causes problems probably about half the ladies. And if you have partners, you have to feel for them, because a lot of men just don't know what to say or do, and they're left feeling helpless. And I really like it when their partners come into the consultations. I had a lady the other week came in with her husband, and I'd seen her a few years ago and I put her on HRT, and then she developed a couple of little breast lumps, and someone told her to stop the HRT because that was the cause of the breast lumps. And she was really suffering, and her husband had been to one of his talks at work, and he realized that his wife was suffering all these symptoms and she didn't need to, so he brought her to me, and we started her back on HRT, and she was fine. And the breast lumps were just it was a bit of a red herring, really. So ladies often want to know where they are with the menopause. If you're on a pill or you're on Depo-Provera or you've got a Mirena coiling, you may not have periods. And one of the good signs to know where you're going through menopause is your periods change. That's probably the easiest sign to look for. But if you don't have periods, or if you had a hysterectomy, you still got your ovaries, you just don't know where you are. As a guide, we don't do blood tests if you're over 45. And if you have symptoms, we just treat you. If you're under 45, between 40 and 45, you can consider testing. But if there's a strong family history of an early menopause or someone has strong symptoms, you just treat. You definitely need to do blood tests if you're under 40, because as Edwin mentioned, there are other potential causes of an early menopause, like hyperlactin, and they do need to be treated. So most ladies will get a full discussion and counselling, and some ladies don't want to take HRT. So there are the things you can do. There are certain foods which are higher in estrogen, like soya. You can stop your smoking and reduce alcohol, because alcohol always makes hot flushes worse, as does caffeine. Exercise if you can. Try and reduce your weight. Some ladies will buy over-the-counter preparations, which we'll come to. Some ladies benefit from cognitive behavioural therapy. A lot of ladies until recently were getting antidepressants because they go to the GP with depression, and as you know, depression is quite high in patients with EDS. But if you don't have a history of depression and you suddenly feel anxiety around the time of menopause, antidepressants is not the first line treatment, it should be HRT. So simple measures, just take regular exercise, light clothing, keep the bedroom window open. There are mattresses you can buy on, because not everyone can take HRT. Breast care patients can't take HRT, and sometimes they're quite young, and they suffer quite a drastic menopause, and they often have lots of problems sleeping. And there are these mattresses you can buy on which cool you down. Try and reduce your stress levels if you can, which is a bit difficult in this country. Avoid the triggers, caffeine, as we said, smoking, alcohol, and spicy foods. There's loads of non-hormonal treatments on the market, and they don't work for everyone. I think to do is just try them and see. Magnesium citrate is very good for sleep and heavy periods. Some people find things like Promensil, which is the thing on the right, which is red clover, that can be quite beneficial, but it is expensive, and it takes like 3 or 4 months to work. But some ladies will often try this and then eventually give up and go to HRT, or some ladies just cut to the chase and go and see their GP and start on HRT. There are various other things you can try. Black cohosh is coming to vogue again. Sage is very good. Various oils can help. CBD oil, and there are new treatments for vaginal dryness as well if you don't want to take HRT. So things of HRT have changed a lot, especially over the last few years. I'm at an age where we used to give HRT out like Smarties, and then this study came out called the WHI, and it caused a lot of scaremongering. You can see how old this is. This is when Nancy, who was married to the football manager, I forget his name now, it showed that HRT doubles risk of breast cancer. Of course, that caused a massive scare. And what happened is lots of ladies stopped taking HRT to their detriment. And what happened in the medical schools is, for a couple of decades, doctors didn't get taught anything. Nothing about HRT at all. So we have a whole tranche of doctors and medical students who didn't learn anything. Fortunately, it's become more into the fore now, and GPs are eagerly learning about it. And the reason is, when they looked at this trial again and dissected it, they realized it was full of errors. So they weren't looking at women who I would normally put on HRT, someone I've just done a hysterectomy on in their 40s, or someone who's in their early 50s with who needs HRT. These ladies were in their 70s and 80s. Some had been on HRT before, some had had heart attacks, some had ongoing problems with their chest and their heart. In America, it's very different. If you go on a study, you get a stipend, so basically you get paid. So that tends to attract a certain clientele, whereas in the UK, if you go on a study, all you do is get your travel expenses. So when they dissected this, they realized, yes, the risk of breast cancer does slightly increase, but we knew that already. But what we did find is that it did help people with osteoporosis, and it actually reduced the risk of bowel cancer by a bit as well. And people were suffering, and so HRT has now come back to the fore. And since the Davina effect, there has been so many shortages of HRT, it can be difficult to actually get the prescriptions now. And I took this just from November last year, saying that HRT may protect protect your brain from dementia and Parkinson's. But for those who are astute and saw the paper a couple of weeks ago, you said HRT may increase the risk of dementia. So you can't always believe what you see and read. So you do have to have a little bit of skepticism. So why do you take HRT? Well, the principles really are you take it for symptom control and the prevention of osteoporosis. Those are the two real reasons you take it. You don't take it because you've got irregular periods in your late 40s and you want to regulate them. That's not the reason for taking it. And for all treatments, as I said before, all women are different and you need to work out the risks and benefits for each individual patient. So who needs the HRT? Well, again, anyone who's got a premature menopause, women who are still having symptoms, but they're still having periods. Those who've got a family history of osteoporosis, sometimes you find ladies have had a fracture of their wrist and they've had at a young age, so they've had a bone scan and they're showing osteoporosis, so they need HRT. And we use it for osteoporosis prevention basically up until the age of 60. So what we prescribe really depends on ladies' age and a few other factors. The easy ladies to prescribe are those who've had a hysterectomy, because if you have a uterus, whether you have a coil in or you've had an ablation, then you do need some kind of progesterone therapy. If you don't have a uterus, you just need estrogen. If you do have one of the coils in, which is the hormonal coil, you can use that as part of HRT. And then depending on your age, you either have an HRT which will give you a bleed every month, or if you're over a certain age, then you can have one where you don't bleed at all. And it's important to remember, if you are sexually active, HRT is not contraceptive. The Mirena coil can be used as HRT and contraception, but otherwise you've got to use some other form of contraception when taking HRT. Because occasionally we do see ladies in their late 40s with a pregnancy. So you don't need to take any notice of this, but when the lady presents, these are all the things we need to think about when we decide what HRT would probably work for this lady. There's about 50 different types of preparations available, and there's more coming onto the market. As doctors, certainly the GPs, they are tied into the local guidelines, so they have to go through their list. So there are different ways of taking HRT. The most common way at one time was oral. But since Davina and a few others have got into the social scene, the transdermal preparation's really taken off. So transdermal is anything through the skin, so that's either a gel or a patch. There's a spray now as well, which you can spray onto your forearms. And there are also little implants, which are little pellets which go into each skin. So these are usually reserved for ladies who can't get on with the other therapies. So for ladies who have had blood clots in the past, or they get migraines, or they've got malabsorption problems, or gallstones or liver disease, they should really try and do a transdermal preparation. And the idea behind that is because it has less impact on the clotting factors. When you start on an oral HRT, there's a very, very small risk of a blood clot within the first 12 months. After 12 months, the risk is gone. But when you use a transdermal preparation, that risk isn't there. You get a steady absorption over the 24 hours. It avoids the liver, so if you have any liver problems, you can avoid that. But of course, if you've got skin problems from EDS, then you have to be aware that there may be absorption problems with the transdermal preparations. And it's not just patients with EDS. I see lots of patients who come to clinic, they're on the patches or gels, and you start them off on it and they come back and a couple of years later, so it's not working for me. My symptoms have all come back. And if they're already on a low dose, it's very easy, you can just increase the dose. But if they are on the maximum dose, what you don't want to do is just stick another patch on, you'll be fine. They may not be absorbing it. So you do the normal things like suggest they check where they're putting it. Best places on tops of the thighs or the lower abdomen. I've seen people put it on their mons pubis, on the pubic hair area. Obviously, it's not going to get absorbed there. I've seen people put it onto their arms, which isn't the best place. But if they're having problems, then this is the time to do blood tests. We mentioned before, there's no point doing blood tests if they're over 45. But if you're on HRT and it's not working for you, you need to think, why is it not working? And the most common reason is it's not being absorbed. So that's when it's important to do blood tests. Before COVID, this gel here on the right called Estrogel. So most ladies start off on 2 pumps, but invariably a lot go up to 4. And before COVID, we used to have so many complaints about it because they said, oh, it takes ages to dry. But since COVID, no, I can't think of a single person who's complained because everyone's got so much more time on their hands. Where a lot of ladies just prefer the patches because you just put them on and change them twice a week. And so you just put it off, put them on and go. So these are some of the vaginal estrogens, and the top one is called Vagifem. You can see the little white tablet at the end, and this just inserts into the vagina and you just click it off. It's been superseded now because this all used to come as one. Now what happens is you get one of these, excuse me, it's called Vagirux, and the tablets you have to put in at the end. And it's fine if you've got good dexterity, but if you haven't, it's important to ask to make sure you have the Vagifem ones. You can buy them over the counter and they're called Gina. And some ladies prefer the cream. So it's basically the same drug, but you fill up the syringe and put it in. So a lot depends on your dexterity. There are some devices, and I use one called Thermopar, but there's several on the market where ladies find, but they can't take topical estrogens because either the breast cancer or they just don't, it doesn't suit them. And we use a device called the Thermopar. What it treats is ladies who are dry down below. Some people have got stress incontinence, which is when you laugh or sneeze, you leak. Some people have what we call a sensitive bladder. That's where you get urgency. A lot of people have pelvic floor disorders with laxity, especially if you've had a child. Some ladies will complain of sort of loose tissue down below. And what this device does using radio frequency energy, it changes the collagen and it remodels it using heat. I must admit, I haven't used it on any EDS patients, but for those patients who I know are not EDS, a lot of them get really good results. I see quite a lot of ladies who have this urgency where they have to rush to the bathroom, they don't get there in time, so they leak. So these ladies were previously using pads and tablets, and they come and have this done rather than wear the pads. So they come every 6 months or so when the symptoms start to come back. So basically what it does, it increases the blood flow in the tissues and increases the nerves as well, and increases the lubrication. So for a lot of ladies, it works really well. It doesn't work for everyone, so you have to be a bit careful with your patient selection. So with HRT, there's a lot of confusion about bioidentical and body identical HRT. So body identical is basically what that means is HRT, which is very similar or similar to the hormones which your own body was making. Now, I can prescribe these, your own GP can prescribe these. The tablets, the patches or the gels, they are all, the estrogen ones, they're all body identical. Again, so it's a Davina effect, everybody wants body identical ones. Now, with the progesterone, most progesterones are synthetic. And we see a lot of ladies who have what called a progesterone intolerance or sensitivity. And they will describe that when they're taking the progesterone, they just don't feel right. It can make them feel a bit low, emotionally out of kilter. Some people feel it nauseous. Sometimes it gives them a low mood. And some of the clues are that they may have had a Mirena before but didn't get on with it, or they took the mini pill when they were younger and it just didn't agree with them. And now most HRT drugs will, if you're giving them for someone who's got a uterus, will have a synthetic progesterone in it. So there is a progesterone you can use called utrogestrone, which is a natural or a body identical HRT. And so the GPs at one time could not prescribe these, but they can now. The bio-identical ones, these are unlicensed hormones. And there are various clinics and they'll do blood tests and saliva tests. They do charge a small fortune. And they will give you an HRT prescribed especially for you. And they give it either as a cream or like a tablet. But these medications are not licensed and they're not regulated. And so I'm a menopause specialist for the British Menopause Society. I'm not allowed to prescribe them. But some ladies do really well on them. But normally we suggest body identical first. So going back to the progesterone intolerance, some ladies cannot even tolerate the natural progesterone as an oral tablet. So for some ladies, we suggest that they use it vaginally. So those ladies who can't take HRT, there's a whole list of drugs out there which you can use. We mentioned antidepressants, which do work for some ladies. Some ladies use progesterone cream. There are tablets like Dixerit, which are for menopausal flushing, and testosterone. So the amount of referrals we get these days for testosterone it seems to be skyrocketing everywhere. And I'm sure a lot of it is due to social media. So taking out the ovaries in a young woman, they will find their libido goes because the ovaries produce about 50% of the testosterone. And when the ovaries are removed at a young age, it is felt quite markedly. So if you give ladies testosterone, it actually improves their mojo, their well-being, and their sex drive. But having a poor libido is multifactorial. If you're in pain or you can't lie on one side or you have pain with sex, that can affect your libido. If you don't fancy your husband or partner anymore, that will affect your libido. So it's not going to sort everyone's problems out. But if it's purely due to a low testosterone level, then it may well work. So it's what we call a red drug, which means your GPs can't prescribe it. So they normally has to go to a specialist, either in the NHS or private. And there are some GPs who can prescribe it, but they usually specialized. So normally we check the bloods to make sure that the levels are low. Then we give the testosterone gel. It's really important you don't use more than recommended. And then we check the blood levels again in about 3 months' time. It's important that the estrogen levels are correct as well, because if estrogen levels aren't correct, the testosterone isn't going to work. A lot of ladies don't think it's working for them until they stop it and realize it was. So testosterone is very much in vogue, and we're quite happy to subscribe it, but because it's off license, we do have to take the bloods. I do believe, and there was a license preparation, which means GPs could prescribe it. And there was a patch about 10 years ago called Intrinsic, and it was taken off the market, I suspect because it wasn't making very much money for the company. But there is talk that this will be coming back to the market, and so GPs should be able to prescribe it, so you won't need to go and see a specialist to get it. One of the other questions we often get asked about HRT is, when should I stop it? And for those of you maybe a bit older in the audience who may have had HRT in the past, you may have been told by a GP, or you've been on it 10 years, Mr. So-and-so, I think you should stop it now, or you're 55 now, do you not think you should stop? And that was the discussions years ago, but that's not the guidance now. The guidance now is basically you should use the lowest possible dose for the least possible time, but it has to be individualized. Some ladies, or if you're working as a teacher, you don't want to be standing up with hot flushes in front of the children. And so we get a lot of teachers who will take HRT until they retire. But there's no arbitrary age limits at which you should stop. It's very much an individual approach. I have ladies who come in their 70s and 80s, and their GP wants to stop their HRT. Admittedly, these ladies have had a hysterectomy, so they're taking estrogen. And I remember one lady, she came a couple of months ago, and she said, I came with a partner, said she can't come off HRT because her memory just goes to pot. And she said, I'm not coming off it. I mean, she's 80, so it's her life. So I said, yes, carry on for as long as you like. But again, you have to weigh up the individual risks and benefits. So the only time you really have to stop is if you ever find a breast lump. So, sorry, a bit of a morbid bit now. So if you look at causes of death in women over 65, you might be surprised to know that the leading cause is actually heart disease. Breast cancer comes in about 4%, and that's what ladies worry about, is breast cancer. But most people are going to die from cardiac disease, stroke and dementia, and Alzheimer's is the other big killer. So 1 in 3 ladies over the age of 65, it's going to be cardiac disease, which normally gets us. And there's really is a low level of awareness of cardiac disease in women against men. You'll hear about men having chest pain in the center and going down their arms, typical for men, but women often present differently, often get indigestion symptoms, or a bit short of breath, or they get palpitations. And sometimes it's not recognized. And you do hear of women in their 50s dying of heart attacks. I know we mentioned before that if you've had an early menopause, then you are potentially more at risk. So it's another good reason to take HRT if you have symptoms. And the reason you're more at risk is that the lipids in your body, so the fat that's in your body, change. And the fat builds up on your arteries called atheromas and atherosclerosis. So men get it from a very early age. And you often hear men having problems in their 40s and even 30s with heart disease and things. But women, you don't hear women in 30s and 40s having it because they're protected. So if you're going to HRT, you're going to take HRT, there's this what we call a window of opportunity. So if you're under 60 and you've got symptoms, it's a good idea to take HRT, because if you start it over the age of 60, you actually increase your risk of heart disease. And this is one of the things which was shown from the studies. So ladies often worry about other medical problems in taking HRT. So diabetes, that's not a contraindication to HRT. Ideally best to use a patch or gel though. Asthma, that's not a problem. Thyroid problem can be affected by HRT. So sometimes if ladies are on thyroid problems, we do check the thyroid levels after 3 or 4 months. Some ladies get migraines. They've never had migraines to get to the perimenopause and they begin. And you have to be honest with ladies, sometimes the HRT works, sometimes it doesn't, sometimes it makes it worse. A lot of ladies have migraines before they had the menopause and they end up just taking anti-migraine tablets as well as their HRT. So breast cancer, clearly this is quite an emotive topic. if there's a lot on this slide, but basically, if you start taking HRT below the age of 50, you don't increase your risk. If you take combined HRT as estrogen progesterone after the age of 50, yes, you do increase your risk, but the risk returns to normal after about 5 years of stopping HRT. I'm going to go on to the next slide because I think the next slides are more important. So one of the things we often hear is, oh, my mother had breast cancer, so I'm more at risk. That's not true. If your mama had breast cancer in the menopause, you're not more at risk. There are genetic factors with breast cancer, and they're called the BRCA genes. So these do run in families, and if you do have the BRCA gene, you are more at risk. But these cancers usually occur in younger women. And so these are treated very, very differently. And some ladies who do have breast cancer, if you look at the studies, the studies are inconclusive about taking HRT or not. Some studies say, yes, it definitely increases the risk, and other studies find that it doesn't. So I've got a few patients who've got breast cancer on HRT. One lady, she came to me 3 or 4 months ago, and she said she lost her mother when she was 30. She didn't actually lose her physically, she lost her mentally because her mother had dementia in her mid-50s. And that's when it started. And she said when she got to the menopause, she wanted to go on HRT because she didn't want to be like her mother, because she was very similar to her mother. So she said, I'm prepared to take the risk. I don't want to get dementia. So it's all a lifestyle choice, really. So if you've had an early menopause, an early start to your period or late menopause, you put slightly more at risk. But if I just skip this one and go to this one. So this one's looking at women between the ages of 50 and 60. And you're looking at 1,000 women over a 5-year period. And if you look at this top line here, these are ladies who've never had HRT. So you're going to get 23 women out of 1,000 over 5 years are going to get breast cancer, never had HRT, not been anywhere near it. If you're taking combined HRT, that's an estrogen progesterone, and these figures are based on oral tablets, not the transdermal preparations. You're going to increase that from 23 to 27. So that's a very, very small increase. If you've had a hysterectomy and gone to estrogen only, you've slightly decreased your risk. But if you're drinking a couple of gins or a couple of glasses of wine every night, that's a greater risk than taking HRT. But the biggest risk of all is being overweight. And if your BMI is over 30, you've doubled your risk of breast cancer. So this all has to be put in context. If you exercise and do 2 to 3 hours of moderate exercise a week, you've decreased your risk. So if you exercise, avoid smoking, avoid drinking, although the odd glass of red wine is good for your heart, then you decrease your risk. The important thing is all women should remain breast aware, because if you report it early, then your prognosis improves. So just coming about some misconceptions about HRT, which were just sort of reminders really. You can start HRT if you're still having periods and symptoms, and you can take it for longer than 5 years and beyond the age of 55. If you've got migraines or high blood pressure, you can still take HRT, but ideally it needs to be transdermal. If you're overweight or diabetic, you don't have to avoid HRT, you can take it, but you have to be a bit wary of bleeding problems. Again, if your mom had breast cancer when she was older, you're not at risk, only if you are overweight. If you've had a blood clot, you can still take HRT, but it has to be transdermal through skin. As long as you're not over 60, it's fine to start HRT. We do get some ladies who are over 60, and if they're fit and healthy, yes, we do start them on HRT. And it's never too young to start on HRT if you have symptoms and got an early menopause. And remember, it's not a contraception, and there are lots of choices as to whether you can use patches or creams or pessaries. And testosterone isn't just for men, it's for women as well. And the question we get asked so much is, I won't grow a beard, will I? Yes, you will if you use too much. But if you use the recommended dose is no, you won't. I've only ever seen one person who grew a beard, and that was a lady, sadly, who, not in my hospital, but an adjoining hospital, the doctor wrote the wrong prescription and gave her like 10 times too much. And unfortunately, with testosterone, if you use too much, some changes are reversible, like the hair, but what's not irreversible is changes in the voice. So just briefly about if you're taking out HRT, why is it not working for me? Well, the most common problems with HRT are bleeding issues. When ladies first start taking HRT, it's very common to get a bit of bleeding, very common to get a bit of breast tenderness, especially if you've not been on HRT, if you've not had any periods for a long time. What the estrogen does, it goes to the tissues which have the most receptors, which is the uterus and the breast. So ladies will often complain of breast tenderness, a bit of enlargement. That usually settles. If the bleeding persists, that needs to be reported. Some ladies have pelvic pain when they start HRT. And earlier in my talk, I talked about endometriosis. So endometriosis is a very common problem. I see quite a lot of patients with EDS who've got endo. And when you get to the menopause, the endometriosis all dies out. But if it hasn't been picked up while you've been having periods, and then you start HRT, what the HRT does, it kicks it all back into touch again. So the endometriosis pain can restart. And some ladies say, I can't tolerate HRT, it's causing me problems, and that may be because they've got progesterone intolerance. So for all ladies, you need to try and maximize your health. So try and eat well, a healthy, balanced diet. If you're a vegetarian, it's a good idea to try and have some calcium, magnesium. I recommend vitamin D. All not just women, but men in the UK should really have vitamin D in the winter months, because we just don't get enough sunshine. I don't know where you're listening to this to, but I'm in just outside Cirencester and it's pouring down with rain here. Not all of us can go on summer holidays or winter holidays, so it is important to check your vitamin D, especially with EDS, with malabsorption and things. Weight bearing exercise. When you move, you don't need to do marathon runs or anything, but just some weight bearing exercise. You don't have to go to the gym. You can just lift up the washing baskets, just the bags of from Tesco's and things. So just some exercise. Ideally stop smoking and try and drink less alcohol, and try and keep your weight a little bit below 28 if you can. It's very difficult. Most people in the UK have got BMIs over 28, including me, but if you can get your BMI down, it does help. And do consider HRT, because you will find it beneficial. So thank you. There are other things I could talk about gynae problems and EDS, but I'll give you some websites to look at. First one's called the DAISY Network. So these are the people who've had a premature menopause. The two really good websites is the bms.org. That's very factual, probably a bit more doctor orientated, but there's a lot of information on there. But a really good one is this womenshealthconcern.org. So I'd encourage you to all have a look at that if you're interested. Thank you.
That's fantastic. Thank you so much, David. That was so informative and really, really insightful. We do have a lot of questions. Heads up, everyone, we're not going to be able to get through them all, but we will try our best. And some of them I've kind of, if they've come up throughout, I have tried to answer in the question and answer box, but we'll kind of flick through as many as possible. Kind of the one of the biggest questions we're coming across, David, would be EDS and progesterone and the impact of progesterone on EDS. You know, is that something that is kind of person specific, or is it something that, you know, all EDS patients are going to have this progesterone issue? What's been your experience with that?
So just taking progesterone generally, so when ladies are having periods, they'll often describe breast tenderness around the time of the period. And if ladies have got a prolapse, which is more common in EDS, then what the progesterone does, it basically causes the body to retain water, but it also relaxes muscle. So that's why ladies get breast tenderness, is because the breasts are retaining water. And a lot of ladies who have prolapse will find that their prolapse symptoms are worse around period time, because the tissues get heavier and the muscles and the tissues holding it up get weaker, so the prolapse becomes more problematic. So progesterone can cause problems. I mentioned about some ladies will have, and it's quite a lot, probably about 20% of ladies will have a progesterone intolerance to some degree. So it's not just patients with EDS, all women can have a progesterone intolerance. But that's why now, fortunately, the GPs can prescribe this drug called eutrogestrone, which is a natural progesterone.
Brilliant, thank you. Just having a little look. Lots of people that say can only tolerate patches, for instance, you know, is that due to things like I know you mentioned about not being able to absorb creams properly, or could it be linked to POTS and EDS and things like that? Or again, is it kind of, I get, you know, through a lot of this talking about, it's very individual to each person.
Yes, so as you know, EDS patients, or you know, I'm sure your audience know EDS far better than I do, but I started off by saying I'm not an expert in EDS. I've got an interest, and the reason I've got an interest is a personal one, because I'm sure a lot of you went on a long patient journey, and my wife and I did with our eldest daughter, and she saw 7 specialists who were my colleagues, consultant colleagues, and they all misdiagnosed her, and eventually we had to pay privately to take her to see someone who diagnosed her with a hip problem and EDS. And with EDS, it's like lots of things at the different ends of the spectrum, and she's at one end of the spectrum. So I'm sure I saw lots of patients with EDS and didn't recognize them in my clinic. The first person I ever saw with EDS was when I was doing my fellowship at Harvard. And this lady presented, she had no children, and she was a thin lady. She didn't do any heavy lifting or anything, but she had a quite impressive pelvic organ prolapse. And I was doing urogynecology, and so we ended up repairing that. So that was my first case. And then once my daughter had been diagnosed, I realized I was seeing a lot more of these patients, and doctors were not recognizing it. And I was seeing patients who come in being under the orthopedic surgeons, and young women had this done and that, and I just picking up. So patients with EDS do get missed. So I'm quite an advocate of trying to pick these ladies up and refer them to the right health professionals. So I digressed a little. So it is, I forget what the question was, sorry.
That's okay, let me put back up. It's to do with patches and kind of creams.
Oh yes, so lots of ladies with EDS do have skin problems and bruising and things, but a lot of the general population, they don't absorb the patches or the gels, and some of it can be purely because of their skin, and sometimes it's the manufacturer, and some people have problems with adhesive. So some ladies may have problems with patches, but they can tolerate, they have problems with plasters, but they can tolerate patches, and vice versa. So the idea of using the patches is not the drug ladies are the problem with, it's actually the adhesive in the patch. So I mentioned there's a spray now you can get called Lenzetto. And the idea is you can spray it on your forearm, but you don't want to spray it in the same area because the reservoirs of the drug build up underneath the skin. So you need to put it on different parts of your forearm. Tablets, if you don't have any problems with absorption and you don't have any real medical problems, I think are the way to go. Because often lots of ladies have problems with patches. If you do a lot of water sports or running, sometimes the patches just don't stick. There is a certain brand of patch which I won't mention, but it's supposed to last 7 days, but it never does. And this patch has been around for 20, 30 years, the doctors are still prescribing it. And I hear the same thing all the time. It stops working after 5 days. So I don't know why they keep prescribing this particular brand, but it's not what I would prescribe. But so if you can tolerate patches or gels, that's great. But if you don't, then I would move to an oral preparation.
Thank you. Someone wanted to know here, kind of, what's the lowest amount of progesterone that you can safely use to provide the protection needed? So if you're taking it, I'm just going to try and some of the questions for a bit, just trying to put them together. If you are very sensitive to progesterone and the effect that it has on your joints, what is the lowest amount you can use so that it still helps for when you're taking it 12 to 14 days a month and then full time?
The only reason you're taking progesterone is to protect the womb. That's the only reason. Although some people find the estrogen, the natural one, that helps sleep. So some ladies who can't take the oral progesterone will use it vaginally. That's off license. So that's probably fine if you're a slim lady, but if you're overweight, it's probably not a good idea, because the fat tissue breaks down and makes natural estrogen, and that's not good for the womb. So some of the things you can do, I mean, with estrogen, it's normally recommended you take 2 tablets for at least 12 days in a month. Some ladies will take one tablet, which is 100 milligrams for 25 days a month. And if you're of a certain age, you should take it every single day. So the ways you can potentially, other things you can do is potentially you could use progesterone. So that gives you the lowest amount of daily progesterone, but it is a synthetic one. There is another drug I didn't really touch on, but it's something which may be worth considering. It's a drug called tibolone. Now, tibolone, also known as Liviol, is a synthetic oral drug, and it's got progesterone qualities, it's got estrogen qualities, it's also got a bit of testosterone in it as well, and it doesn't have to be monitored. Now, the advantage of this drug is that I see a lot of ladies with endometriosis, and I mentioned in my talk about ladies start on HRT, they may not have been diagnosed with endometriosis or fibroids early, and taking HRT suddenly brings their pain or bleeding back. But what the tibolone does, what it doesn't do, it doesn't stimulate the lining of the womb, it doesn't stimulate endometriosis, and it doesn't stimulate fibroids, and it's got a bit of testosterone. So if you don't have any contraindications to taking oral therapy, that's something else which you could consider. The downsides of tibolone, there's always downsides for everything. The one downside is that some ladies find that it doesn't control the hot flushes as well as the estrogen HRT. But then again, you can take other things to control hot flushes. Some ladies, and it is a small cohort of ladies, they find that they gain weight. But conversely, some ladies, because they get their mojo back and they got a bit of testosterone in them, they find that they are able to do more exercise and they lose weight. So that's something you could try.
Perfect, thank you. Just having a little look here. And have you come across in clinic and things? We had a question here about autism. We know that there seems to be a link between EDS and autism. And someone just wanted to know about if you're coming across people within clinic, women within clinic that are autistic with EDS, and trying to kind of make sense of what's going on menopause wise, and kind of the best way to advocate for themselves to get appropriate treatment and support.
I must say, I don't see many autistic patients in my clinic. I see quite a few ADHD, AHDH patients. I think, well, I try and encourage most people to take HRT. And I'm trying to persuade my daughters when they come of age and I'm not around anymore that they take HRT as well. Because I think it is beneficial.
Yeah.
For most ladies.
Perfect, thank you. Just having a quick scan through questions. Some of these have been answered, so I'm just scanning through. Someone here has been perimenopausal since age 36, now 49, using a stim machine, but it's causing extreme pain. Is this something that they should kind of persevere with, or kind of go back and say, actually, this isn't working? Can we have a look at something else? Using the stim machine for vaginal prolapse currently.
Okay. So sorry, the stim machine is not working, or the prolapse is getting worse?
So the stim machine, looks of it, it's causing just extreme pain for days. So
I wouldn't use it. Depends on what the prolapse is. I mean, there are lots of new things coming out for prolapse and things. So for like incontinence now, there's lots of devices you can put inside the vagina, disposable ones, which work for stress incontinence. That's leakage when you cough and sneeze. I mentioned about the Thermivar, but there's a thing called Caress Flow, which delivers oxygen and hyaluronic acid to the vaginal tissues, and that's supposed to be quite effective. It's very popular in Italy at the moment. I'm sure it's going to come to the UK soon. With prolapse, prolapse is so common. Probably about 1 in 2 ladies has got a prolapse. If you've had a vaginal delivery, 1 in 2 ladies has got a prolapse. So they are depending obviously with EDS, they can be more pronounced. But you don't have to have EDS to have a bad prolapse. Sometimes you see it in young women. So there are pessaries, a whole type of pessaries you can use, and certainly younger women, we encourage them to use to self-manage with pessaries. You can get pessaries which be like a dice, or call it a cube pessary, and you basically pop it in the morning, and then you just take it out in the evening. You if you're obviously just pottering around the house for the weekend, you're not going out, not bothering you, don't use it. But if you know you're going on a long day with a family or whatever, then you might put it in then. There are other pessaries if you're not sexually active, which can be put in, usually not by the GP but by the hospital, and that will hold the prolapse up. So there's lots of things which can be done besides these machines.
That's really helpful, thank you. It's good to know as well that, kind of like I said, sort of other things that can be tried, and kind of instead of just kind of trying to battle through with something that's not.
Also, like lots of ladies buy all these Kegel 8 machines, which they don't work for everyone.
Perfect, thank you. Someone who had a hysterectomy but left leaving ovaries and cervix, and on HRT, they are finding that once a month it still feels like their ovaries are trying to ovulate, that it still feels like they're creating cysts. Would their HRT need to be adjusted or left in case of, kind of, does the dose need to be changed, or is it kind of that's just going to happen because the ovaries are there? So
when you have a hysterectomy and take the ovaries out, that's an immediate menopause, and the hormones go off a cliff. But when you leave the ovaries behind, they can potentially carry on working. So it's the same as if you've got a uterus, your ovaries are still going to carry on working, but they wax and wane. So if the lady was bad enough to start on HRT for symptoms, then it doesn't mean the ovaries are just going to suddenly stop. They will potentially carry on producing a bit of estrogen. When you've still got the cervix, I didn't really touch on this, but if the lady was still having spotting every month after her hysterectomy, she needs to be on an estrogen and progesterone. If she didn't, because then she can just be on an estrogen. It's quite important now, because when you do hysterectomy and leave the cervix behind, if you've left some of the cells of the womb in the cervix, when you're just taking estrogen only, that could potentially lead to problems.
Thank you. Another one that's quite interesting as well. So a lot of the symptoms for menopause and EDS kind of correlate: brain fog, for instance. There's kind of lots of crossover symptoms. Is it how do you differentiate And would it be a case then of kind of the easiest thing to do would go and ask for a blood test to see where hormone levels are at and go that way?
Yes, I would, because I mean, as you know, patients with EDS get anxiety and get a lot of other symptoms. So, and there is confusion, and you can't blame everything on the menopause. There are people have other conditions as well, and of course, if you've been labelled as EDS, it's very easy. Oh, it's just your EDS. It may be an early menopause, and people just haven't thought about it. So I think when you've got an underlying of a condition, whether it's EDS or some other systemic disease, it's a good idea to get the blood tests. The blood tests are, I say, not recommended if you're over 45, and that goes for patients with EDS as well. There's no point because your ovaries will be failing. But certainly if you're younger, it'd be worth having hormones checked. If you're still having periods, it's really important that you have your bloods taken within the first 4 days of a period. That gives you the most accurate result. But I'm seeing ladies in clinic who don't have EDS, and they're in their early 40s, 40, 42, 43, and they've got symptoms. And you do the blood test, they'll come out normal, but they've still got symptoms. So the only thing you can do is try them on HRT for 3 months. And if their symptoms go away, you know it's due to the menopause. If they don't go away, it's something else.
It's just elimination.
So HRT is, you know, it does what it says on the box. It's hormone replacement. It's just replacing what your body's not making anymore. If your thyroid gland stops working, and you go to your GP and your thyroid levels are low, they're going to give you thyroxine to actually increase levels, and that's all the same they do with estrogen. Your glands, your estrogen glands, your ovaries aren't working as well as they used to, and you're just topping them up or replacing it.
Brilliant, thank you. Someone here has been asking about Everel or Everel. See, I'm going to mispronounce this. Yes, they have a Mirena coil, but each time they see a GP, each GP is telling them to have one or the other. So they're kind of saying, not having periods, have a Mirena coil, which one should I be taking? Because the GPs can't decide.
So if you've still got a uterus and you're of a certain age, you have to have estrogen and progesterone in a combination, which is Everol Sequi. And basically what that means is every month you'll have a bleed. But if you haven't had a period for 2 years, then you can use something else. But if you're at that age group, I suspect this lady is, then she'll be given an option of Everol Sequi. So what that contains is 4 patches of estrogen only, and then there'll be 4 patches of something called Everol Conti, but they call the whole box Everol Sequi. So that's 2 weeks with estrogen only, and then 2 weeks with estrogen and progesterone, and that will cause a bleed every month, or should do. If a lady is using that, she has to use contraception. Now, the other option is a Mirena coil, which gives you the progesterone and the contraception. And then for the estrogen, you just need the patch or a gel. So the advantage of the Mirena coil is it will give you HRT and contraception for 5 years. If you're the problem with the Mirena coil is it's a bit like Marmite. People will either love them or hate them. So if you've had a normal delivery, it would not be a problem fitting the coil. But if you've had a cesarean section or you've not had children, it may be a bit more difficult to fit the coil. So you need to go to someone who does a lot of them. But it is just personal preference. I mean, the safest way to take HRT without a shadow of a doubt is a Mirena coil and a patch or just the safest way, especially if you've got underlying problems.
Good, thank you. Someone's asking in terms of kind of breast issues, if you're someone that gets cysts in your breast, would you need to stop HRT, or is it more lumps and issues that are linked to cancers, or kind of any breast issues?
Well, some ladies have naturally lumpy breasts, and ideally you should examine your breasts every month, or you get your partner to, so they are familiar with what they feel like. So when some patients are examined at the hospital and the doctor's never examined that particular lady's breast before, they don't know. They can just make an assessment. But women should know their own breasts. and if they've changed, also a lump, then you obviously need to see a GP. But so the HRT you can get hormonal changes with the breasts, but unfortunately, breast cancer is very common. I mean, I'm not sure if your audience are aware, but breast cancer is probably about 1 in 8 ladies in their lifetime is going to get breast cancer. So it's very high.
Yeah.
If you compare that to ovarian cancer, 1 in 50 ladies will get ovarian cancer. Men, if you've got partners, prostate cancer is 1 in 8 as well. But with your breasts, at least you can examine them every day if you want. But certain things like prostate and ovaries you can't examine.
Yeah.
So that's why we encourage people to be breast aware. And if you do develop breast cancer and you're on HRT, the HRT is always going to get the blame, but the chances are you're going to get breast cancer anyway. And what the HRT has done is made it found earlier, because if you're on HRT, you're probably examining your breast a lot more than your neighbor next door is not on HRT. And these days, if you go early, and it's not a pleasant patient journey by all means, but most ladies will survive it.
Yeah, getting in there early, and that's a really good point actually, that kind of knowing your body is extremely beneficial, and if it's the kind of thing that pushes you to know your body, then it's something that's good. I'm just having a quick scan through. Someone asked here, they've been on Cleovance for a number of years, and they've been told to move on to patches. They say everything's been going well with the tablets. Is there any reason to need to move on to patches?
Stay on the tablets.
Okay.
Because the risk of the blood clot's gone is past if you've been on it years. It's a really good drug. Don't change. If something's working for you, don't change. There's no point. You only change if you've got bleeding problems or something needs to be investigated. But if you've been on it that long and it's working for you, just keep on.
Perfect, thank you. In terms of the kind of osteo issues that arise, can that be helped with, would exercise be helpful with that? We've got a few people saying they've got, say, osteoporosis, they've got osteo issues. Where do they, is exercise going to help with that, or is it kind of that's where it is?
No, so with osteoporosis, as I mentioned, all women will get bone thinning when they get to menopause. So taking HRT helps prevent that. But if you've got EDS and you've got malabsorption problems, then you may be further up the curve, starting that curve before you actually hit the menopause. So it's important that you do weight bearing exercises, because it's the exercises which keeps the bone strong. So if you've got osteopenia, which is thinning of the bone, the advice is obviously weight bearing exercises. Take HRT, make sure you have calcium and vitamin D. If you've got osteoporosis, you should really be under the rheumatologist at some stage and having other drugs for osteoporosis. Walking is one of the best exercises, brisk walking, and just doing sort of little weights with your hands and things.
Brilliant, thank you. Some of these have been answered. Someone just wanted to know the name of the natural progesterone, because they missed the name of it.
It's called Eutrogestrone.
Eutrogestrone, perfect. There's lots of, I'm sitting there, there's lots of thank yous because of the company at the end, which is always very nice to see. Let's just see. Is there a best time of the day to be taking HRT?
No, that really depends on your personal preference. Certainly with tablets, you can take them morning or night. If you're using the gels, if you're using 2 pumps of gel, some people put one in the morning, one at night. But if you're up early and to work or whatever. Some people will put on in the evening instead. So it's just personal preference.
I think one of those times when you remember to, to do it.
So some people just stick it by the toothbrush.
That's a very good idea. If you brush your teeth twice a day, like you should.
You brush them twice a day, really.
Let's have a look. Have you? I'm not. I'm not sure if you've come across MCAS before. We've had a few MCAS questions. I'm aware it's kind of slightly off topic, but people saying about allergies to creams and things. Would it be better to go down a natural route or more synthetic, or go to patches or tablets if you're having reactions to things and your body tends to react to things?
I'm just going to close my window. Got the rain coming in. There's some people do react. So in the tablets, they put sometimes lactose in. So some people are lactose intolerant. And similarly, the natural progesterone, it's actually got quite a lot of soy in it. So some people have a soy allergy, and so you end up having to take an antihistamine as well at the same time. So some people do. It's not actually the drug itself; it's the substrate is what's in with the drug as well, which sometimes causes the problems. So a lot of ladies do have lactose intolerance, and that's why a spray or a patch would be better. So it's just finding the right combination for you. Perfect,
thank you. Ladies here just said there's, and I'll share these links with you, David, a couple of researchers at Bournemouth University doing some research into women with autism and menopause. So just sharing the links to that, which I can share with everyone.
There was a British Menopause Society meeting last week in June, and one of my colleagues actually presented a paper on patients with mental difficulties and the menopause. And that was actually, I think, it won the first prize.
Oh, amazing.
I'll see if I can look it up and send it to you.
Perfect, thank you. Just having a quick look. Do you have a kind of percentage? I know it's quite difficult with things like this in terms of HRT, and so approx percentage of HRT getting rid of symptoms, and that's going to be a kind of difficult one to.
It depends what your symptoms are. It really helps with the hot flushes and the brain fog and the anxiety. And often ladies will say within a couple of weeks a cloud has lifted. That's what the majority of people say when they go onto HRT, and you can just see by all the shortages that people do want to stay on HRT. And but there are women who with HRT it just doesn't agree with them. They don't feel well on HRT. So it's not for everyone. But I think the one people get least response with is the testosterone, because I think sometimes their expectations are a lot higher for what they're led to believe. You're not going to, if you're in your 50s, you're not going to have a sex life with a 30-year-old again. It just isn't going to happen.
Yeah.
So, but the estrogen definitely does help. There's very few people who actually stop HRT because they say, I still want my symptoms. Most ladies will carry on with it.
Perfect, thank you. Just checking the time, I think we've got time for, say, 2 more questions. One is, if you've had a hysterectomy, should you be offered HRT afterwards, even if you've retained your ovaries, for instance? If you've had a hysterectomy, should it be the norm that you should be offered HRT after that?
Not straight away. If you're young when you had the hysterectomy, the ovaries are probably still working, but it's like patients with EDS, they are thought to have a slightly earlier menopause than the average woman. Similarly, women who smoke, while I was having early menopause, if you had a history of anorexia, eating disorders, malabsorption, more likely to have an earlier menopause. If you've had your uterus out, it compromises the blood supply to the ovaries. So the ovaries get their blood supply, one from the uterus and one from the aorta, which is the big blood vessel. So you're knocking off at least 50% of the blood supply. And sometimes the ovaries will work for quite a long time afterwards, and sometimes they've stopped working after 6 months. So certainly if a lady's under 45 and got symptoms, they need a blood test. But certainly it shouldn't be given HRT straight away, because there's no point keeping the ovaries if you can give them HRT straight away. But they may need it, well, they will need it at some point, yes. But when that is, it depends on symptoms. But as I mentioned, there are some ladies who don't have symptoms, so people do need to be on top of their own health. Certainly, like DEXA scans, even if you pay privately for them, they're only about £120. So if you can afford that, it's probably worth getting a DEXA scan, because that's really important, I think, with people with EDS.
That's a good idea. A good idea. Like you said, if it's something that it's in terms of kind of getting access to, it's on the much kind of lower end thing, it's getting investment as well. And then the last question, just to wrap up, if you've got endometriosis or adenomyosis, can you take HRT? Is that kind of seen as okay to do?
You can take it, but you have to be careful, because I sort of alluded this into the lecture. So sometimes this lady obviously knows she's had it or got it, but HRT can make it worse. So it depends on how bad your symptoms are. But I mentioned tibolone. Now, tibolone won't affect endometriosis. It won't stimulate it. It won't stimulate adenomyosis as well. But unfortunately, if you're still having periods and you've got symptoms, you can't take tibolone. So for those ladies, it may be better to maybe consider a Mirena and some low dose HRT. I end up doing loads of hysterectomies on these type of ladies, because they can't survive without the HRT, and the HRT just makes their adenomyosis and endometriosis worse. Because in the end of the day, if they can't tolerate the tibolone and they can take it, and they still want to take HRT, a lot of them will opt for a hysterectomy, and then they just take the estrogen for going forwards.
Fantastic, thank you. Thank you ever so much, David. It's been
That's my pleasure.
Really, really informative, and lots and lots of thank you comments in the chat. So thank you, and how amazing and informative it's been.